Good day, I am Dr. Go. The topic for this lecture is adrenocorticosteroids and their antagonists. Here is the outline of this lecture. Our main reference is the latest edition of Katsung. This topic is found in Chapter 39. Here are the learning outcomes. At the end of the lecture, you'll be able to discuss the biosynthesis of adrenocorticosteroids, to identify and differentiate the naturally occurring corticosteroids from their synthetic counterparts based on their pharmacologic properties, to differentiate the antagonists based on their mechanisms of action and pharmacologic effects, to identify the roles of corticosteroids and their antagonists in adrenal and non-adrenal disorders. And lastly, to determine the important adverse effects of these drugs. This is the adrenal gland. We have two of these on one on top of each kidney. The adrenal gland is made up of the outer cortex and the inner medulla. For this chapter, we'll be focusing on the three steroid hormones produced by the adrenal cortex. These are mineralocorticoids, glucocorticoids, and androgens. We remember them by their effects through the mnemonic salt, sugar, and sex. Mineralocorticoids help us retain salts. Glucocorticoids increase our sugar levels, and then adrenal androgens contribute to the normal maturation process. These are the three major pathways in the synthesis of adrenocorticosteroids, which derive from cholesterol, a 27-carbon molecule. The first step of synthesis begins with the cleavage of cholesterol side chain by the side chain cleavage enzyme. By removing 6 carbon atoms, we now have a 21-carbon molecule called pregnenolone, which is the major precursor of aldosterone, our major endogenous mineralocorticoid. The 17-alpha hydroxylase acts on pregnenolone to add hydroxyl group at position 17, producing 17-hydroxypregnenolone, which is the major precursor of both cortisol and DHEA. Without this enzyme, we will have low levels of these two hormones and high levels of aldosterone. The synthesis of adrenal androgens continue with the conversion of 17-hydroxypregnenolone to DHEA by 1720 lyase. All adrenal androgens are weak. DHEA is the most abundant form and is eventually converted to testosterone, a potent androgen. For the next steps of synthesis in the mineralocorticoid and glucocorticoid pathways, the precursors undergo the same three major reactions. Let's focus on cortisol. After its hydroxylation at position 17, it will undergo dehydrogenation at position 3 and isomerization of double bond from B ring to A ring. After this step, it will undergo two more hydroxylation reactions at 21 and 11. Now we have cortisol. To sum it up, to synthesize cortisol, we cleave the side chain of cholesterol, add a hydroxyl group at 17, remove hydrogen from 3, move double bond to 4, and add hydroxyl groups at 21 and 11. Adrenal androgens are steroid hormones with weak androgenic effects. Its primary role was to initiate and contribute to the development of pubic and axillary hair. As mentioned earlier, DHEA is the major form of adrenal androgens and is converted into other weak androgens such as androstenedione and androstenediol. Androstenedione is then converted to testosterone in the peripheral tissues. Adrenal source of testosterone production accounts for less than 5% in men, so its effects in an adult male is negligible. However, in women, it accounts for around 50% of total testosterone production, so premenopausal women with adrenal androgen excess may present with cystic acne, hirsutism, menstrual irregularities, anovulation, infertility, or frank virilization. In contrast, postmenopausal women have significantly lower levels of estrogen, and since testosterone is converted to estradiol by aromatase, DHEA becomes the major precursor of estrogen for postmenopausal women. In 2016, Prasterone, by the brand name Intrarosa, is the first FDA-approved drug containing DHEA, which is available as vaginal inserts for treatment of painful sexual intercourse due to dryness and thinning of vaginal tissue and vulvovaginal atrophy. This is caused by the decline in estrogen production after menopause. Prasterone is not mentioned in Katsune. So far, the book discussed studies that showed a small benefit of DHEA in treating patients with SLE and in women with adrenal insufficiency. There is no evidence to support its use to increase muscle strength. The use of DHEA in sports competitions is prohibited by the Anti-Doping Association. Since adrenal androgens have little to no clinical application, corticosteroids generally refer to mineralocorticoids and glucocorticoids. Corticosteroids should not be confused with anabolic steroids, which are synthetic derivatives of testosterone, and like DHEA, they are banned in sports competition. These are the naturally occurring corticosteroids and their synthetic counterparts. Let's start with the endogenous ones. Aldosterone is the major endogenous mineralocorticoid. 11-deoxycorticosterone, or 11-DOC, is the precursor of aldosterone, but its mineralocorticoid activity is significantly less than that of aldosterone. For glucocorticoids, the major endogenous form is cortisol, also known as hydrocortisone. Cortisone is an inactive metabolite of cortisol. Side by side, we see the similarities and differences of our major endogenous corticosteroids. Both are primarily metabolized in the liver and excreted by the kidneys. Both receptors are intracellular or nuclear receptors. They are initially found in the cytoplasm, but once the hormone binds to the receptor is activated and moves into the nucleus to start gene transcription and subsequent protein synthesis. Mineralocorticoid receptors bind both aldosterone and cortisol with similar affinity, but because 20% of cortisol is converted to cortisone, which is its inactive form, cortisol has much less mineralocorticoid activity. In contrast, glucocorticoid receptor binds to cortisol with affinity 10 times greater than that for aldosterone, so aldosterone has minimal glucocorticoid activity. When we say mineralocorticoid activity, we mean salt-retaining activity. Angiotensin II, high levels of serum potassium, and ACTH stimulate the secretion of aldosterone, which leads to two major effects: reabsorption of sodium and excretion of potassium. Water follows salt, so excessive retention leads to increase in plasma volume and blood pressure. Excessive excretion of potassium leads to hypokalemia, whereas excessive excretion of hydrogen leads to metabolic alkalosis. Because there is only one synthetic mineralocorticoid, I'll discuss that before I move back to cortisol. Fludrocortisone is the only synthetic mineralocorticoid. It binds to mineralocorticoid receptors with greater affinity, exerting potent salt-retaining activity for use in adrenal insufficiency with mineralocorticoid deficiency. Because it's given at a low dose of 0.1 mg 2 to 7 times weekly, it has negligible glucocorticoid effects. Remember, fludrocortisone is our synthetic mineralocorticoid. Be careful not to mistake it for glucocorticoid. Fludrocortisone is not the same as cortisone, which is an inactive metabolite of cortisol. Now let's discuss the major endogenous glucocorticoid, that is cortisol. This picture describes the interaction of a steroid with its receptor. The steroid, or more specifically cortisol, breaks free from the corticosteroid binding globulin, or CBG, and enters the cell to bind to the glucocorticoid receptor in the cytoplasm. The stabilizing proteins bound to the receptor are released, allowing the steroid receptor dimer to enter the nucleus, bind to the glucocorticoid response element, or GRE, on the gene, and regulate transcription by RNA polymerase. mRNA is edited and exported to cytoplasm for protein synthesis and subsequent hormone response. We also have a regulatory system that is the HPA axis, with the hypothalamus secreting CRH, stimulating the anterior pituitary to secrete ACTH, which then stimulates the adrenal cortex to secrete cortisol. In a negative feedback loop, sufficient cortisol suppresses the release of both ACTH and CRH. Quantities of aldosterone are insufficient to participate in the negative feedback, so cortisol is the only corticosteroid that participates in the HPA axis. The rate of cortisol secretion follows the circadian rhythm governed by the pulses of ACTH that peak in the early morning and after meals. 90% of cortisol is bound to CBG. The remaining 10% is free or loosely bound to albumin, which can be considered as free because albumin has low affinity for cortisol. 20% of cortisol is converted to cortisone by 11-beta dehydrogenase type 2 in the kidney, so there is less cortisol to bind to mineralocorticoid receptors. They bind instead to glucocorticoid receptors with great affinity and produce the following effects. Firstly, the metabolic effects of cortisol include gluconeogenesis, glycogenesis, muscle proteolysis, and lipolysis, which as a result increases serum glucose levels and stimulates insulin release. Other major effects of cortisol include anti-inflammatory activity and immunosuppression. Excess cortisol will lead to decrease in muscle mass due to excessive breakdown of muscle protein. In general, excessive catabolism weakens not just the muscle, but also the skin, the bone, and impairs the growth in children. There are many other toxic effects that will be discussed later in detail. In the previous slide, it was written that cortisol stimulates gluconeogenesis and glycogenesis. This might be confusing, so here is a slide to answer the question. Gluconeogenesis, proteolysis, lipolysis, and inhibition of peripheral glucose uptake all contribute to the maintenance of an adequate glucose supply to the brain. If the goal of cortisol is to increase serum glucose levels, how and why would it stimulate storage of glucose through glycogenesis? Now, in contrast to catecholamines, which are the hormones in the fast stress response, glucocorticoids are responsible for the long-term stress response. So by using excess hepatic glucose from gluconeogenesis, cortisol stimulates the synthesis of glycogen to set aside glucose, which will be subject to breakdown by glucagon and catecholamines in times of need. This goes to show that our bodies are capable of preparing for future needs even under stressful conditions. There are two components of stress response. More well known is the role of epinephrine, or also known as adrenaline, in the fast response. This is mediated by the sympathetic adrenal medullary axis. After the initial phase, the HPA axis is activated. Cortisol as the primary stress hormone comes into play for the body to preserve function by producing glucose for energy and suppressing the inflammatory and immune response. Overall, the stress response is normal and adaptive, but it may become maladaptive with chronic exposure to stress. Here in this table, I summarize the mechanisms through which cortisol suppresses the inflammatory and immune response. Firstly, it inhibits the migration of neutrophils to the site of inflammation. So, there is an increase in neutrophils in the circulation. In contrast, all other leukocytes exit the circulation and return to the lymphoid tissue. Cortisol also inhibits the functions of tissue macrophages, limiting their response to antigens and their production of inflammatory cytokines. The suppression of both lymphocytes and macrophages decreases the production of interleukin 12 and interferon gamma, both of which are inducers of T cell immune response. Cortisol inhibits a wide range of inflammatory mediators, such as platelet activating factor, eicosanoids, and histamine. So, corticosteroids inhibit platelet activating factor and eicosanoids by increasing the synthesis of annexin A1. Annexin A1 inhibits phospholipase A2, thereby reducing the synthesis of arachidonic acid, the precursor of eicosanoids, such as leukotrienes, thromboxane, and prostaglandins. Annexin A1 also inhibits the expression of COX-2, thereby directly inhibiting the synthesis of prostaglandins. Cortisol suppresses mast cell degranulation and histamine release, causing vasoconstriction and decreased capillary permeability. Now, we move on to synthetic glucocorticoids. Synthetic glucocorticoids are of animal or plant origin. The glucocorticoid molecule is synthetically modified to prolong its half-life and duration of action. These are some of the alterations. Dexamethasone contains multiple alterations. Firstly, the halogenation at position 9, specified here as the addition of fluoro group. Next is the unsaturation, also known as addition of double bond at position 1, 2. These alterations make dexamethasone a long-acting and highly potent glucocorticoid. With increased potency comes undesirable mineralocorticoid effects, which are countered by the addition of methyl group at position 16. Alterations in the glucocorticoid molecule affect the duration of action by influencing its affinity for the glucocorticoid receptor, its affinity for protein binding, lipophilicity, and side chain stability. Synthetic glucocorticoids produce the same effects as cortisol, but they have different ratios of glucocorticoid to mineralocorticoid potency. Here we see the difference between endogenous and exogenous glucocorticoids. With the addition of double bond at position 1, 2, prednisone and prednisolone have longer half-life. As a prodrug, prednisone is metabolized in the liver and converted to its active form, prednisolone, in order to exert anti-inflammatory effects. Here is the summary table of synthetic preparations of corticosteroids. Hydrocortisone is the pharmaceutical preparation of cortisol. Together with cortisone, they have the shortest half-life and are the least potent glucocorticoids. However, the ratio of glucocorticoid to mineralocorticoid potency with hydrocortisone is 1:1, making hydrocortisone the drug of choice in adrenal insufficiency, where both glucocorticoids and mineralocorticoids are deficient. Now, the increase in half-life translates into an increase in anti-inflammatory effect, which is part of glucocorticoid activity. Betamethasone and dexamethasone are long-acting and the most potent glucocorticoids. With synthetic alterations, the longer-acting glucocorticoids have no salt-retaining activity. On the other hand, fludrocortisone, the synthetic mineralocorticoid, has potent salt-retaining activity of 250 at 2 mg, but we treat mineralocorticoid deficiency at a low dose of 0.1 mg, so the anti-inflammatory activity is negligible. Synthetic glucocorticoids are used to treat not only adrenal disorders, but a variety of non-adrenal disorders. They are effective in inflammatory conditions, and depending on their location, preparations are formulated to maximize local action and avoid systemic effects that would result from oral or intravenous administration. So we have nasal sprays for allergic rhinitis, inhalers for bronchial asthma, A wide range of topical formulations for dermatitis, triamcinolone is just one of them. Suspension for injection to be administered intramuscularly or intra-articularly for arthritis, and ophthalmic solutions for inflammatory eye conditions such as uveitis. In case of increasing severity without improvement, we then switch to oral preparations. In general, oral prednisone is used in autoimmune diseases such as rheumatoid arthritis, lupus, and Graves' ophthalmopathy. It is also used in subacute thyroiditis, nephrotic syndrome, and hematologic cancers such as leukemia and lymphoma. Another important application of prednisone is its prevention or treatment of organ transplant rejection. It reduces antigen expression from the grafted tissue, delays revascularization, and suppresses the host immune response. Prednisone is also used to treat hypercalcemia from excess vitamin D by interfering with absorption of calcium. In 2020, there was evidence showing that a dysregulated immune response resulting in an hyperinflammatory state known as the cytokine storm, and this response is a major cause of death in patients with severe COVID-19. Dexamethasone was found to decrease mortality for these patients by 30%. The antiemetic mechanism of dexamethasone is not well understood, but it's been long used for patients at low risk of developing nausea or vomiting from chemotherapy or from anesthetic agents used in surgery. One of the theories is that dexamethasone exerts anti-inflammatory effect by inhibiting prostaglandin synthesis. Dexamethasone also reduces cerebral edema by decreasing the permeability of blood-brain barrier to sodium. For mothers at risk of preterm labor before 34 weeks, we give them dexamethasone 6 mg intramuscularly every 12 hours for 4 doses prior to delivery. This is done to accelerate fetal lung maturation and prevent respiratory distress syndrome after birth. Now we move on to adrenal disorders. First, we have a rare genetic condition in Cross's syndrome, where there is a generalized glucocorticoid resistance, which means the HPA axis is not able to sense the presence of glucocorticoids, so it responds by increasing ACTH, which results to excess production of aldosterone and androgens. We treat this syndrome by suppressing ACTH with high doses of dexamethasone, which is a potent glucocorticoid without mineralocorticoid activity. Dexamethasone is also used in diagnosis of Cushing syndrome, and I'll discuss more about this in another slide. Finally, one of the major reasons why we administer exogenous corticosteroids is because the endogenous production is decreased or absent, such as in congenital adrenal hyperplasia, Addison's disease, adrenal crisis, and after surgical removal of the adrenal gland. The glucocorticoid of choice for hormone replacement is hydrocortisone because it has a 1:1 ratio of anti-inflammatory and salt-retaining activities. The difference in the management of chronic adrenal insufficiency and that of acute insufficiency is the need for high dose of hydrocortisone in acute insufficiency. This is because there is a higher requirement for cortisol during high-stress events such as adrenal crisis and surgery. A high dose of hydrocortisone will produce both glucocorticoid and mineralocorticoid activities. After the patient is stabilized, hydrocortisone is reduced gradually to maintenance dose, and fludrocortisone is resumed when hydrocortisone dose is less than 50 mg per day. Rapid reduction may bring about withdrawal symptoms such as nausea, vomiting, lethargy, fever, and joint pain. Therefore, it is important to be slow during dose adjustment. In congenital adrenal hyperplasia, the most common form is caused by the deficiency of 21-alpha hydroxylase due to mutations in CYP21A2 gene. Cortisol production is decreased, prompting ACTH to stimulate the production of adrenal hormones. Both mineralocorticoid and glucocorticoid pathways are blocked by the enzyme deficiency. So there is accumulation of the precursor 17-hydroxyprogesterone, which is diverted to the androgen pathway. In simple virilizing form, male infants usually appear normal or have penile enlargement. But female infants would present with ambiguous genitalia, having an enlarged clitoris that looks like a penis and fused labia that looks like scrotum. In the simple form, the enzyme deficiency is partial, so there is still sufficient enzymatic activity for aldosterone production. So hydrocortisone is given to replace the lack of cortisol. On the other hand, there is a complete enzyme deficiency in the severe salt wasting form. Treatment requires both hydrocortisone and fludrocortisone. The less common forms of congenital adrenal hyperplasia are caused by deficiency of other hydroxylases. Both deficiencies block glucocorticoid pathway and result to an accumulation of 11-DOC, which has mineralocorticoid activity of its own. With 17-alpha hydroxylase deficiency, the mineralocorticoid excess is more pronounced because the androgen pathway is also blocked. So these patients will present with not only hypogonadism but also hypertension and hypokalemia. In these forms of CAH, hydrocortisone is given. Since 11-DOC has mineralocorticoid activity, we will not give fludrocortisone. We add fludrocortisone only when there is severe salt wasting form of CAH from a complete 21-alpha hydroxylase deficiency. This flowchart is a simplified version of what was discussed about congenital adrenal hyperplasia. Dexamethasone is the glucocorticoid of choice for preventing specific fetal abnormality because it readily crosses the placenta. Mothers at risk of preterm labor before 34 weeks must receive a short course of dexamethasone to accelerate fetal lung maturation and prevent the baby from developing respiratory distress syndrome at birth. If parents are affected or carriers of CAH gene, the female fetus is at risk of developing genital abnormalities as early as first trimester. So mothers are usually started on daily dexamethasone once pregnancy is confirmed, and the course is continued until term if the fetus is confirmed to be affected with CAH. However, long-term use of glucocorticoids is associated with increased risk of adverse drug reactions. Recently, glucocorticoids were found to have epigenetic effects, which may predispose the children to depression or metabolic syndrome. These are important considerations for the mother before consenting to treatment. Dexamethasone is also used in the diagnosis of Cushing syndrome, which is a clinical syndrome resulting from chronic exposure to excess glucocorticoids. The source of glucocorticoids may be exogenous or endogenous. The three endogenous sources are pituitary adenoma or Cushing's disease, which accounts for 70% of cases, followed by adrenal tumor and ectopic tumor. In general, treatment involves surgery or radiation therapy. Dexamethasone suppression test is done to check for Cushing syndrome to differentiate it from pseudo-Cushing, which is primarily caused by alcohol or psychiatric disorders, and to localize tumor that cause Cushing syndrome. If the tumor is in the anterior pituitary, then dexamethasone will be able to send a strong signal to the pituitary and to suppress its stimulation of cortisol secretion. As a result, serum cortisol levels will decrease by about 50%. However, if the tumor is in the adrenal gland, then it has already chronically suppressed the pituitary secretion of ACTH. So ACTH level will be low and will not react to the presence of dexamethasone. And lastly, if the tumor is ectopic, then we have an external source of ACTH. So the overall ACTH level will be high and will also not respond to dexamethasone. When glucocorticoids are used for less than 2 weeks, it is unusual to see serious adverse effects, but insomnia, behavioral changes, and acute peptic ulcers may be observed after a few days of treatment. In contrast, when patients are given daily doses for longer than 2 weeks, iatrogenic Cushing syndrome and adrenal suppression may occur. For Cushing syndrome, I created a string of adjectives to describe the manifestations by group. Patients with Cushing syndrome are weak because their immune system is suppressed, allowing H. pylori to invade and peptic ulcer to form. Patients also have impaired wound healing and are at risk of contracting infections. Patients may become blind from cataracts or glaucoma. Although dexamethasone can decrease intracranial pressure by reducing cerebral edema, long-term administration can put the patient at risk of developing severe rebound intracranial hypertension after steroid withdrawal. This is associated with marked loss of vision. In Cushing syndrome, the patient's body is broken due to catabolic effects of glucocorticoids, with the skin prone to bruising and striae formation, muscle wasting, and osteoporosis. Patients have body fat redistributed to the face, the trunk, supraclavicular, and nuchal areas. They also gain weight from the metabolic effects resulting to glucose production, which brings us to sweet because they have hyperglycemia, which puts them at risk for diabetes. Moreover, they retain too much salt and water, developing hypertension, hypokalemia, which are mineralocorticoid effects resulting from high doses of glucocorticoids. Patients may be sleepy and moody due to insomnia and display behavioral changes ranging from hypomania, depression, to psychosis. Finally, children may be short because of impaired growth. Doctors should be careful in giving glucocorticoids to patients with pre-existing medical conditions that are underlined on this slide. In general, corticosteroids are not usually curative. The therapeutic benefits must be carefully weighed against the risk of serious adverse effects. Chronic systemic therapy should be undertaken with great care, especially in patients with comorbidities. It might be helpful to obtain chest x-ray and tuberculin tests prior to therapy because glucocorticoid can reactivate TB. Due to possible glucocorticoid dependence from chronic use, patients on low doses of glucocorticoids may require dosage increase in times of stress. While receiving glucocorticoids, patients should have high protein, high potassium diet with adequate doses of vitamin D. Again, if there is a plan to reduce the dosage or discontinue the drug, it must be done gradually to prevent withdrawal symptoms and adrenal crisis. There are two major drug groups of adrenocortical antagonists. We have receptor antagonists and synthesis inhibitors. We also have mitotane by itself as the drug for adrenal cancer. For synthesis inhibitors, we have aminoglutathione that inhibits the side chain cleavage enzyme, preventing the conversion of cholesterol to pregnenolone. This means all pathways are affected. Next, we have ketoconazole, which is an antifungal that inhibits nearly all the enzymes, thereby affecting all three pathways, all enzymes except for 21-alpha hydroxylase. Abiraterone inhibits 17-alpha hydroxylase and 1720 lyase, affecting glucocorticoid and androgen pathways. With abiraterone, we still have aldosterone. Trilostane inhibits 3-beta dehydrogenase, affecting mineralocorticoid and glucocorticoid pathways. With trilostane, we still have DHEA. Finally, we have etomidate and metyrapone that specifically inhibit 11-beta hydroxylase, affecting just the glucocorticoid pathway. With these two drugs, we still have an intact androgen pathway and 11-DOC for mineralocorticoid activity. On this slide, we also see the clinical uses of the synthesis inhibitors. Aminoglutathione is used with ketoconazole or metilropone in patients with Cushing syndrome due to adrenocortical cancer who are not responsive to mitotane. Ketoconazole is a potent non-selective inhibitor of steroid synthesis and has been used in the treatment of patients with Cushing syndrome. Its inhibitory effects on the P450 enzymes in the synthesis of steroids require a dose higher than that needed for antifungal effects. However, this drug is hepatotoxic and should be started at 200 mg per day, slowly increased by 200 mg every 2 to 3 days up to a daily dose of 1000 mg. Abiraterone is the newest synthesis inhibitor approved for the treatment of refractory prostate cancer. Trilostane has long been withdrawn from human use in 1994 and is now used to treat Cushing's disease in dogs. Etomidate is the only IV medication available in the treatment of severe Cushing syndrome. It is also used for induction of general anesthesia in sedation. Metilropone is the only adrenal inhibiting medication that can be administered to pregnant women with Cushing syndrome. You can imagine Tyra being a pregnant woman with Cushing syndrome. The major drug reactions to metilropone are salt and water retention as well as hirsutism. These are attributable to mineralocorticoid and androgen effects that result from inhibiting 11-beta hydroxylase. As a diagnostic agent, metilropone rules out adrenal tumor and tests the ability of pituitary gland to produce ACTH. Increase in ACTH indicates a normal response to metilropone. Finally, mitotane is a drug related to the DDT class of insecticides. It has a non-selective cytotoxic action on the adrenal cortex, inhibiting the synthesis of adrenocortical hormones. About one-third of patients with adrenal carcinoma show a reduction in tumor mass. The use of mitotane was limited due to severe GI and neurologic effects. Mitotane has been withdrawn from the US market but is available on a compassionate basis. Mifepristone is a glucocorticoid receptor antagonist. Its role in adrenal disorder is reserved for inoperable patients with Cushing syndrome due to adrenal carcinoma or ectopic tumor. As a progesterone receptor antagonist, mifepristone is mainly used in combination with misoprostol for medical abortion. Spironolactone and eplerenone are steroidal mineralocorticoid receptor antagonists or simply aldosterone antagonists. Sodium and water are excreted, potassium is retained. Spironolactone is used to reverse manifestations of primary aldosteronism resulting from excessive production of aldosterone. As a diuretic, it is used to treat resistant hypertension and reduce mortality in heart failure. As an androgen antagonist, it is sometimes used to treat acne and hirsutism in women. Eplerenone is more selective and does not block androgen receptors. Like spironolactone, eplerenone is used to treat hypertension and heart failure, but its efficacy is not proven to be superior than that of spironolactone. So the American College of Cardiology recommends trying spironolactone first, only switching to eplerenone if the patient develops anti-androgen effects such as menstrual abnormalities, gynecomastia, and impotence. Drospirenone is an analog of spironolactone. It is a unique progestogen with aldosterone receptor antagonism. It's mainly used as an oral contraceptive. Finerenone is a new, non-steroidal aldosterone antagonist that is more potent than the steroidal agents in inhibiting the mineralocorticoid receptor. It has beneficial anti-inflammatory, anti-remodeling, and anti-fibrotic properties in the kidneys, heart, and vasculature. It is approved for treatment of hypertension and heart failure. This diagram is taken from Katsun Board Review. It shows the prototype for each drug group. All the drugs in this diagram are synthetic preparations. This table is also from the same source and summarizes the MOA, clinical applications, pharmacokinetics, toxicities, and drug interactions of the drug prototypes. Thank you for listening to this lecture. If you have any questions, please email me.